Hello, everybody. Welcome to this latest topic that we'll be discussing on our Arrhythmia Academy portal. It's a very interesting conversation piece. What to do when you are faced with a difficult transseptal puncture. What are the different kind of scenarios you might face, and what are the tools that you have to overcome these situations? I am Dhiraj Gupta from Liverpool in the United Kingdom, and I'm delighted to be joined by my friend Pasquale Santangeli, who, as all of you know, works in Cleveland Clinic in the US. He's a very experienced electrophysiologist who must have done hundreds, if not thousands, of transseptal punctures. And he will be spending some time with us today, just going over some tips and tricks that he has learned over his experience regarding this. So, Pasquale, welcome.
Thank you, Professor Gupta. Indeed, I'm delighted to be part of this. And in the next 10 minutes, I'll cover mostly three main aspects, I would say, where we can get some challenges with transseptal access. And you can see them in the first slide. I'll cover multiple prior access history, which is correlated with septal scar. And sometimes it's quite challenging to pass our dilator and sheath across the septum. It's even more relevant now as we use larger bore sheaths for procedures like pulsed field ablation, for example. Aneurysmal septum is something that we encounter not infrequently, actually. It's very redundant, and we'll see what the challenges are in that case. And finally, we'll talk about patients with percutaneous closure devices, which is an increasing population, especially with the increased usage of PFO closure, but also patients with surgical patches and prosthetic material. All right, so you can see here, this is an intracardiac echo picture with a probe that is actually deployed in the mid-right atrium. So we're looking from above here. And you can see there is color Doppler on the mitral valve. But here, what I want to focus on, I'm not sure you can see my mouse, but there is a fossa vallis here that is quite thick. These are patients with multiple prior ablation procedures. And typically, when we do see that, we can anticipate some challenges with crossing. And that's an example, for example, aneurysmal septum. We know that we can screen for it in a standard TTE or transesophageal echo sometimes, but this is an intracardiac echo picture again with the probe in the middle of the right atrium. And you see there is, of course, bulging during normal conditions. We know, of course, catheterization done yet. You can see there is bulging from the left atrium to the right atrium because of differential pressure, of course. But when you try to tent here, since there is a lot of redundant fossa vallis, you end up in a situation where the fossa vallis will be pushed against really very close to the roof of the left atrium and close to the pulmonary veins. So with that standard needle in these conditions may be complicated really to advance safely because you may be really within striking distance really from the roof of the left atrium and the left pulmonary vein. So usually we like to use RF power tools like radiofrequency needle wires to cross this. And if you use a regular BRK needle, you have to be very careful when you advance it because it can really jump forward and cause some perforation of the left atrium or even the pulmonary vein. So typically in these cases, after we get access, the standard approach is to put a guide wire, typically in the left superior pulmonary vein, and you see here, and then over the guide wire, you will have a rail that you can use to advance your dilator and to pass your sheath through. Because sometimes with the fossa vallis being so redundant, you can actually basically push the fossa vallis all the way close to the pulmonary vein. So having a guide wire as a rail is always a good technique, really, to increase safety of the crossing with the dilator and sheath. So typically, the way we do that, we go to the left superior pulmonary vein. But here, I want to make a point here that really when we are trying to transmit forces from the IVC to the left pulmonary vein, sometimes, of course, the angle is not ideal because we're coming coming from below, from the IVC. So we're going like north here. But then we have to make a turn leftward to the left superior pulmonary vein. So sometimes it's quite challenging to make this turn and to push the sheath over. So really, if you encounter a difficulty to cross with a wire on the left superior pulmonary vein, a much more natural way of advancing the sheath would be to position your wire to the right superior pulmonary vein as a second. We do that sometimes when we cannot cross with the left superior pulmonary vein. And the reason being is that in this case, you can transmit the force like much more coaxial to the septum. It's much easier to cross with this type of angle of access. So it's something that you can use as a trick when you have difficulty even with a wire in the left superior pulmonary vein. Closure devices here, so you can see this is a patient, of course, with mechanical aortic valve, and also you can see a PFO here closure with an Puncture device. This is the most common type of devices, and as I show you here, these type of devices do have a specific architecture. So typically they have a central core, there is very dense mesh here of metal, and as you go to the periphery, it gets a little bit less dense here, which is important for patients that don't have a safe way of accessing around the device, and we'll talk about that in a second. But essentially, in the large majority of patients, we use these devices to close the patent foramen valgus, so the PFO, which is very anterior and superior. And as a result of that, there is almost always a portion of the fossa valgus which is inferior and posterior to the bottom portion of the device that you can still use for accessing the left atrium. You can screen for that with a pre-procedural CT scan, with a TEE, you can see a transesophageal echo. You can actually see that. But here, of course, in the US, we use a lot of intracardiac echo. And this is a picture, again, that you can see there is an Amplatzer device. And on the bottom right, you can appreciate we have tenting the fossa valgus right underneath the PFO closure device. And this can be used for single or double transeptal in most patients. The fluoroscopic views, RAO in the top left and LAO in the bottom left here. You can see how the sheath is actually positioned right underneath and slightly posterior to the, as you can see in the aerial projection here, to the PFO closure device. So this is the large majority of patients you can get that. We actually reported our experience in 2011 with transseptal catheterization in patients with atrial septal closure devices, and here we included 39 patients with atrial fibrillation, and most of them had Amplatzer devices, 82%. But here what I want to show you is that the large majority of patients were, first of all, we did CT in all of them because we didn't know what was the anatomy of the septum at that time, and now we pretty much stopped doing that because we use intracardiac echo or TEE in some cases. And here what I want to show that the large majority of patients, out of these 30 patients, so more than 90%, we were able to access the left atrium, but just by targeting a portion of the fossa valgus that was not covered by the Amplatzer device. As you can see here, we are tenting of the fossa valgus, the Amplatzer is on the top here, and again in the fluoroscopy, typically you are underneath and slightly more posterior in this location. You can access this in the large majority of patients. And here you can see the sheath across and the Amplatzer above, so there is enough room here even for double transseptal catheterization when necessary. Now, when the Amplatzer device is used or the closure devices are used for ASD closure and not for PFO closure, what you end up having is a device that actually covers the large majority of the fossa valgus. It's different than a PFO closure. In these cases, there is really not much room around the device, and we also have reported a technique to puncture across through the device. When you do that, as you can see here on the, first of all, on the left side is an intracardiac echo picture. You see the Amplatzer device covering the entirety of the fossa valgus. On the right, you can see our puncture in the LAO projection. It was like AP, like middle shallow, probably 10 degrees LAO projection here. And you can see that the wire is crossing the periphery of the device. And the reason why we do that is because on the side, on the periphery of the device, the mesh becomes a little bit less dense and you're able to perforate through and to also dilate those. If you want to do this, again, you have to be at the periphery, and you always have to make sure you're not close to the central knob of the device where the mesh becomes very dense and becomes almost impossible to perforate through. Perforation is done here with a standard needle because radio frequency really is not able to penetrate through metal because it gives you impedance issues, impedance mismatches. But after you have that, you can wire the pulmonary vein, and you can either sequentially dilate, and we have dilators now that can go up to 13, 14 French with different devices, or you can also use a balloon septoplasty. We'll talk about that in a second. Here you see in this case we did double transseptal actually. One may argue that in these days we don't really do much of double transseptal. It was the old days when we use lasso catheter here, as you can see for mapping. But essentially this just to highlight the safety and the efficacy of doing puncture through the Amplatzer device as long as you are on the side of the device. Just for full disclosures, all of these patients had an Amplatzer device in a chronic position for more than 6 months, actually most of them more than a year. I would not advise to do this in a patient with a fresh implant of the Amplatzer device because you may encounter risk of dislodgement of the device and also fresh thrombus inside the device. The most challenging types of patients are the ones that really have prosthetic material that sometimes you can even see. At least a patient with a Gore-Tex patch that was placed surgically for an ASD closure. And Gore-Tex is very stiff material, and that's why it's used in construction for a variety of applications. And here in this case, we just could not pass the sheath in the left atrium. So what we use here, we use a specific wire. It's called a Torre wire, which is used for mitral clips, really. It's a large loop wire, very stiff. We advance it to the left atrium here. It's something you can consider. Then we position a dilator across. But despite this very stiff rail, we were not able to pass this through. So in these cases, what you can do is atrial septoplasty, something that has been done fairly routinely for mitral clips, for example, and other interventional procedures. Here we did it for AF ablation, but essentially what you want to do is over the same wire, you can advance a balloon catheter. Usually we use 2 to 4 centimeters length, so it's a peripheral balloon, and the size of the balloon catheter has to be sized to the outer diameter of the sheath. For example, if case of the Agilis sheath, which is the affectable sheath, or Visigo or other sheaths you use typically, although the inner lumen is about 8.5 French, because of the deflection mechanism, the outer lumen goes up to nearly 12 French. So here we're using a 6 to 7 millimeters balloon actually to dilate. We dilate the fossa valis here. You see a little bit of waste here that it gets completely relieved after the Gore-Tex has been exposed, has been completely expanded. And after that, you can deflate the balloon and advance sheath over the balloon to gain access to the left atrium, just like here. So the balloon itself serves as a dilator, really. You dilate the fossa valis, you deflate it, and then you advance your sheath, and you can get your sheath across. So these are the 3 main scenarios. I had something also on interruption of the IVC one. Maybe we can talk about this in the discussion. So thank you for your attention.
No, thank you, Pasquale. That was a very elegant presentation. And you have covered the most common challenging scenarios that we electrophysiologists face in the lab, so which is an aneurysmal septum, fibrosed septum because of multiple previous ablation attempts, and the presence of an ASD device or a PFO device, sometimes with a Gore-Tex patch because of surgery. So I think you've shown us some nice tools. One of the things that keeps coming up for conversation is the role of radiofrequency needle and the radiofrequency guide wire. How often do you feel we need to use both of these?
Well, the need to use it really is not that much that you actually need to use it because you can go across. But it does allow for a more safety profile in a way, especially when you're training fellows and other people that are less proficient with transeptal. Reason being is because you don't have to have really any forward pressure, forward force to cross the fossa valis. It just says as long as you're touching, you're tenting minimally, radiofrequency will be able to go across, and usually it's 15 to 20 watts. So that's the safety aspect of it. The needle is just similar to a BRK needle. So, but the difference is that you don't have to push the needle in. You just have to tent slightly, and then a ref will do the rest of it. For the wire, the safety is really potentially even higher because with the wire, it will loop with a pigtail. Most wires have a pigtail in the left atrium after the perforate with radiofrequency. And it creates also a very stiff rail. So it's kind of almost like 2 steps in one, really, that you can have. And over that rail, really, it's almost nearly impossible to perforate. And in that sense, I think we use it a fair amount here because it minimizes the number of exchanges, which is always important for potential embolism and air embolism, really. But also it's actually more comfortable to watch trainees actually do that procedure as opposed to being with a regular needle. Yeah.
Sure. I mean, we in Liverpool also have a fair amount of experience with the so-called Versa Cross needle, as you know, which is the radiofrequency guide wire. So it allows you quite safe access into the left atrium, and then when you advance the wire, it loops up into the left atrium like your Torre guide wire, which allows you to quite safe advancement of the sheath into the left atrium. So we tend to use it for those cases where we are foreseeing problems. We don't use it routinely because of cost reasons, but I'm aware of many centers that do. So the other thing that often gets asked about is, now, as you rightly said, we are now going to the single shot technologies with large sheaths, whether it's pulse field ablation, whether it's cryoballoon, and whether we need to have a specific transseptal setup for that. Do we still need to have a conventional sized BRK1 needle and then swap over to these large sheaths, or whether we can do direct transseptal punctures with appropriately sized, appropriately length needles with these long sheaths? So what are your thoughts about that?
Right. So great question. I have no personal experience with using needles actually of adequate length for these large bore sheaths, really. Typically, the way we work with this, we either puncture with a regular needle, then we put a wire across, a stiff wire, and then we exchange in the left atrium. So, and we usually, for puncture, we use an SL sheath. It can be really any type of band, SL0 all the way to SL3, really. Doesn't really matter. But typically, we work with SL1, honestly. But again, that doesn't matter. Once it's across, then we exchange it with a wire. Or the other option is to use RF power tools like, for example, the VersaCross wire or the RF wires in general. You can actually do the puncture with that and with the large bore sheath directly, fairly safely, after you verify that you're tenting in the right place. And I think for this is actually even more important because for this, especially for PFA, but also cryoballoon, the site of transeptal puncture is quite relevant in the way how the procedure will go in terms of how easy it will be to cannulate every single pulmonary vein and to achieve coaxiality with the veins. So having these RF wires helps because sometimes you have to rewire. If you're not in the right place, you have to go up again in the SVC, and then you save several steps to do that, as opposed to having a needle where you can actually have to pull back the needle and rewire up to the SVC if you want to repuncture or choose a different location for your transeptal. So that's the reason why we like to use mostly the pigtail wire, RF wire, the VersaCross one for these cases.
Absolutely. And obviously, you mentioned that in the United States, you tend to use intracardiac echocardiography quite a bit. Situation is different in some other countries, including the United Kingdom and Europe, where they tend to do most of the transseptal punctures without imaging, whether it's intracardiac echo or transesophageal echo. Do you have any thoughts about that? Do you think that imaging is perhaps necessary for all cases, or you think that we should be reserving it for those cases where we foresee difficulties?
Yeah, so I think the track record of fluoroscopy only for transeptal in Europe and other places as well has been excellent. So in other words, if you look at the complication rate, it's very extremely low. So it's hard to make that one better in some ways across the board. But in patients with, again, like the ones that we discussed in this lecture, for example, with prior multiple access, with patches, or also intracardiac baffles, we didn't talk about that much, and closure devices, I think having images is quite relevant because in those cases, really, you need to target specific areas of the fossa valis that are difficult to determine where they are really on fluoroscopy only.
True. Yeah. I agree with you entirely. Now, one of the things that really concerns a lot of electrophysiologists is what happens if you can't access the fossa valis or the intratracheal septum from below because of interruption of the IVC or some anatomical difficulty like that. So would you be able to give us some tips and tricks as to how do you access the fossa valis from above, perhaps?
Right, absolutely. This is so we have two options, of course, in those cases. We either go transhepatic, which is an option when you have an IVC obstruction. It does require collaboration with interventional or IR, really, mostly. And then in patients that are on oral anticoagulation, there is some risk of bleeding with intrahepatic puncture. So I personally prefer to use a superior venous approach from the SVC, really. And there are different ways of doing that. This is just like in this slide, you can actually see the prevalence, we say, is fairly low, although all of us will at some point encounter a case of IVC obstruction, really. So the way we've done that, really, we started with the right IJ for our transeptal approach, but now we transition to the right axillary vein as opposed to the left. The reason why I think the right axillary is actually the best approach is because all of you that have done devices, you realize that it's quite difficult to do it, go to the right ventricle from the right axillary because everything is pushed septally, and it's very difficult to go through the tricuspid annulus with that sometimes. I mean, it's definitely feasible, but more difficult than from the left. But it's actually good for us for transeptal access because you're naturally basically pushed against the fossa valis, so it's actually easier to tent and also easier to retain access during the procedure. So just an example here. Again, we use intracardiac echo, deflectable sheath, in this case coming from the IJ. And here it's very simple. You pull back the leader slightly, and you basically deflect the sheath until you see tenting. And now the puncture can be done with any really tools, but the preferred tools is VersaCross, in this case, is the pigtail wire. That's what we've been using. Because once you're tenting there, you can position your pigtail wire in the left atrium. As you can see here, it's perforating, and it's actually now advanced within the left atrium. And after it's in the left atrium, you can actually access with your dilator and with your sheath, and then you do your full procedure that way. So we reported this technique in about 15 patients, actually. It was quite safe. All patients were done on uninterrupted oral anticoagulation. And really, we have seen no significant, no complications really related to the transseptal axis in this specific patient population. Of course, from an ergonomic perspective, it's not the most pleasant procedure to do because you've been standing very close to the anesthesiologist, which is not that we don't like anesthesiologists. It's sometimes it's difficult to have enough space for both of us. So the IJ is actually the worst in terms of ergonomics. That's why the right axillary is actually even better for us, because really you end up working just like a device from the right side. So it's actually easier also for us to work when there is enough room for everybody. But in addition to that, the benefit is that you get closer to the septum, easier to cross, easier to tent, and easier to retain access after that. So you can use essentially the same tools that we discussed before, just from a different angle, and it's been shown to be safe.
Perfect. Well, thank you very much indeed. I think we are coming to the end of the allocated time, so we'll have to draw it to close. So I really wanted to thank you, Dr. Pasquale Santangeli. You've really taken out time for us from the US. We are grateful to you on behalf of the Arrhythmia Academy. And I'm also thankful to all the viewers and listeners who are going to join us for this. I hope you found it useful, and we look forward to seeing you next time. Thank you very much indeed.
Thank you so much for having me.